And this slide shows some therapeutic application of the tetracyclines. Continue, we will discuss the adverse effect of the tetracyclines. Adverse effect of tetracycline. And from the pharmacokinetics of tetracycline, we have learned this tetracycline could be deposited in the bone and teeth. It can cause staining on the teeth or cause the development delay of the bone in the younger adult. So it's here. Bone and the teeth is a major adverse effect of tetracycline. Bone development delay and the teeth staining yellow can often meant after the tetracycline usage. This is a major adverse effect of tetracycline. Gastrointestinal adverse effects is another adverse effect of tetracycline. As some patients, after taking these engines, and some patients will feel uncomfortable in the stomach. The third one, tetracycline could cause the liver and the kidney toxicity. It will cause some liver and kidney damage, especially in elder patients after taking the tetracycline. Please remember. The fourth adverse effect, photosensitization and vestibular disturbance. So some patients could feel sensitivity to the sunlight after taking the tetracyclines. It feels some skin rash, feel some other uncomfortable in the skin. So these patients, if after taking the tetracycline, the doctors will give the suggestion they could not go out to directly to exposing to the sunlight. The last one is another major adverse reaction is the super infections. We have learned in the beta-lactam antibiotics, the fourth and the third generation of sulforins has the super infections. And here we mention another type of the antibacterial effect. They have also has the super infections. So what's the concept of the super infections and what's the definition of the super infections? Definition: super infection means there is a complete microecosystem in healthy adult. After long-term using broad-spectrum antibiotics, please remember here, after long-term using the broad-spectrum antibiotics, all the broad-spectrum antibiotics could or maybe cause the super infections. So after long-term using the broad-spectrum antibiotics, sensitive bacterial growth is inhibited. Non-sensitive bacteria takes the chance of breeding, resulting in new infections. This concept we called super infections. Super infections. In this slide, we can join conclusion. Super insect is easily caused by some broad-spectrum antibiotics. At this time, every student, you have learned two types of antibacterial agents could cause the super infections. First one, the sulforins, some third and the fourth generation of cephalosporins. Another one is here, tetracyclines, all cause these super infections. Here, we give two examples of super infections. The first one is the mycotic infections. This mycotic infections is a super infection. It's always caused by some antifungal drugs. Another examples of super infections is Pusae membranous carcillitis. This super infection is caused by the vancomycin and the metronidazole, these two agents. So this is the two examples of super infection. That means some other antimicrobial agents could cause the super infections besides the third and fourth generation of cephalosporins and the tetracyclines. And here, some antifungal agent and the vancomycin and the metronidazole could also cause the super infection. This adverse reaction. Okay, it's here. We have discussed the natural tetracyclines, the pharmacokinetics, antibacterial effect, antibacterial spectrum, adverse reactions, and the therapeutic application. This is the nature of penicillin. Another one, we select one semisynthetical tetracyclines for showing some the difference between the natural and the semisemic tetracyclines. Here, we select the doxycycline, doxycyclines. This is the semisynthetical tetracycline. The antibacterial spectrum is the same to tetracycline. In other words, the doxycycline is also another broader spectrum antibacterial effect. This is the seminal difference. The antibacterial effect is stronger than the tetracycline. So semisynthetical tetracycline has a stronger antibacterial effect compared with the natural tetracyclines. Resistant Staphylococcus aureus to the tetracycline or oxytetracycline is still sensitive to doxycycline. This, in other words, the natural cycline and the semisynthetic centrally is here to the doxycycline has no cross resistance. The last one, besides the doxycycline, the others, semisynthetic tetracycline and the natural tetracycline, it has cross resistance. Please remember, besides the doxycyclines, other semisynthetic also can not, the other bacterial has produced resistance to the natural tetracycline is also not sensitivity to the semisynthetic tetracycline. This is a doxycycline. So, for the clinical application of the doxycycline, please remember, doxycycline is the first choice of tetracycline in clinical application. That is, doxycycline at present is combined with other agents for some bacterial infect. In clinical application is the same to tetracycline. This sentence means the doxycycline is not widely used for some gram-positive or gram-negative bacterial infections disease, because it also has the good effect on the gram-negative or gram-positive bacterial infection compared with some beta-lactam antibiotics or compared with aminoglycosides or chlorophenicals. The last clinical application, it is specially adapted for the infections of biliary system or accompanying to renal failure. So this is the doxycycline's advantages. It's used in clinical. It's specially adapted for the infection for the biliary system or renal failure infection patients. At this time, the doxycycline, I think, is good, the first choice for this engine's infections disease. Okay, it's here. We have finished the tetracyclines. This chapter, tetracycline. Continue, we'll discuss another one, chlorophenicol. Chlorophenicol. Chlorophenicol, it is antibiotics generated from the Vanillina staphylococcus. So chlorophenicals, it's also called the natural antibiotics. Natural antibiotics. And chlorophenicol now also can be generated by some chemosynthesis. So the chlorophenicol can also produce via the natural, for example, the Vanillina staphylococcus. Also, it can be produced by some chemosynthesis. This is the first synthetic antibiotics in clinical application. And because of the different chemical structure, its left isomer is used in clinical. In other words, in left isomer, this type of the chlorophenicals has the perfect antibacterial effect. This is chlorophenicol, some characters or history of the chlorophenicol. And the chlorophenical's antibacterial spectrum. Last class, we have discussed the tetracycline. We compared the antibacterial spectrum of tetracycline. We have learned the tetracycline has a less antibacterial effect on the gram-negative bacteria compared with the chlorophenicol or aminoglycosides, right? It's here. Chlorophenicol is also another broad spectrum bacterial stantic. It's a bacterial stantic. It's a strong effect to the gram-negative bacteria. Its major antibacterial spectrum is the gram-negative bacteria. It is germicide to the Haemophilus influenzae, Diplococcus intracellularus, and the Streptococcus pneumonia. This is for its agent, the therapeutic application. The effect to the gram-positive is not as good as penicillin and the tetracycline. So it's here, chlorophenicals. Chlorophenicals is a broad spectrum antibiotics, but its major anti-effect is on the gram-negative bacteria. It has less effect to the gram-positive bacterial compared with the beta-lactam antibiotics. It can repress the recantous organism, Chlamydium and Mycoplasma. Chlamydium or Mycoplasma. So this is an antibacterial spectrum of the chlorophanicol. Please remember, this agent is a major effect on the gram-negative bacteria. It has a less effect on the gram-positive bacteria. So it's the antibacterial spectrum of chlorophanicol. Mechanism of action. This mechanism of action means the mechanism of chlorophanicol antibacterial infection. Similar to the tetracycline, chlorophanicol is another patent inhibitor of microbial protein synthesis. In tetracycline chapter, we have learned tetracycline also could inhibit the protein synthesis by binding to the surface subunit of the A site. It's here that chlorophanicol acts primarily by binding reversibly to the 50th subunit of the bacterial ribosome. This is a different target site. Tetracycline, the target site is the 30th subunit of the bacterial ribosome, and chlorophanicol target site is the 50th subunit of bacterial ribosome, and interferes with the peptidyl transferase in the stem of protein synthesis. So while this way, the chlorophanicol could inhibit the microbial protein synthesis. Another one, please remember, chlorophanicol is a bacteriostatic antibiotics. It is not a bactericidal antibiotics. This is different between the beta-lactam antibiotics. It's a bacteriostatic antibiotics. Resistance. Almost all the microorganisms could develop resistance to the chlorophanicol. Because of this reason, the chlorophanicol is not widely used in clinical because of its high resistance of the bacteria. The resistance usually is caused by a plasmid encoded acetyltransferase that inactivates the drugs. This is the resistance of the chlorophanicol. Another one, pharmacokinetics of chlorophanicol. Pharmacokinetics of chlorophanicol. Chlorophanicals is label solubility. This is physical characters of the chlorophanicol. High concentration in the cerebrospinal fluid. Because of its physical or chemical characters, the chlorophanicol could easily pass the BBB. What is BBB? Brain-blood barrier. It's a high concentration in the cerebrospinal fluid. So its distribution is widely, besides to the lung, kidney, liver, or others. It also can distributed in the brain. So high concentration in the cerebrospinal fluid. The third, most of the drug binding with the hyaluronic acid in vivo eliminated by the urine. So this is the excretion of the chlorophyll. It is almost eliminated by the kidney. So if there are some patients, the renal function is impaired, impairment, so these patients cannot be used with the chlorophyll. It will cause the severe damage to the kidney. Clinical application. Clinical application, as we have mentioned the last slide. Due to its severe adverse effects, chlorophyll is seldom used in clinical. Seldom used in clinical. It is used only when the benefits of the therapy outweighs risks of the potential toxicity, and there are no other antimicrobial agents to select. In other words, this sentence that means in clinical, if we have no other choice for application in clinical, at this time, the chlorophyll could be used and could be selected for the clinical application. And at present, for the clinical application of the chemotherapy, it's for the chlorophyll, for the typhoid fever, bacterial meningitis, anaerobic infections, rickettsial disease, and blue cyanosis. That's these types of infection disease. In clinical, we could select the chlorophyll to apply in clinical. This is a clinical application. In this line, we have mentioned, due to its severe adverse effects, chlorophyll is seldom used in clinical. So, what is the severe adverse effect caused by the chlorophylls? And this is the major content of chlorophyll in this chapter. So, adverse effects of the chlorophyll, it's all serious adverse effects. The first one is the bone marrow disturbance. Bone marrow disturbance. Bone marrow disturbance, it has two types. One is reversible. Another is aplastic anemia. One is the reversible anemia. Reversible, this means it can be reversed by stopping usage of the chlorophyll. And what is reversible anemia? Reversible anemia is apparently dosage related and occurs concomitantly with the period of treatment. This is the reversible anemia. This is dosage related. So if we decrease the concentration of chlorophyll, or it's a stop the usage of chlorophyll, this one, reversible anemia, could be reversed or could be stopped. First. Second, compared with reversible anemia, aplastic anemia is severe. It will cause the death of the patients. Aplastic anemia is idiosyncratic and usually fatal, which is not related to the dosage and therapy. So if some patients, after some patients taking chlorophyll, and some patients will easily got this aplastic anemia, and easily cause the death of these patients. And at present, the research means aplastic anemia is usually caused by some inherent gene mutation. Inherent gene mutation. It cannot be reversed by other management and cannot be improvement by some clinical applications for it. This is the first adverse effects we call the bone marrow disturbance. The second adverse effects we call the green baby syndrome. What is the green baby syndrome means? That means the chlorophyll accumulates in newborn infants. If some newborn taking this type of agent, it will cause the chlorophyll accumulation in the body of the newborn. Because of this newborn infants lack an effective glucuronic acid conjugation mechanism. Because lacking of this acid conjugation, it cannot metabolize effectively chlorophyll. So it will lead to accumulation of the chlorophyll in the host. It can cause this green baby syndrome. This is also another severe adverse reaction caused by the chlorophyll. The third, others, dural infection, gastrointestinal adverse effects, and allergic response. But compared with the bone marrow disturbance and the green baby syndrome, this one, dural infection, gastrointestinal, and allergic response is not severe. So I hope every student please remember the first and the second severe adverse effects caused by the chlorophyll. Okay, it's here. We have finished the chapter 44, tetracycline and chlorophyll. Continue to discuss chapter 45, amyloglycosidal antibiotics. Amyloglycosidal antibiotics. Amyloglycosidal antibiotics that including these agents. And please remember some names of these agents. For example, gentamicin, tobramycin, amikacin, kanamycin. This is all the amyloglycosidal antibiotics. And we discuss the physical or chemical property of the amyloglycosides. They are all alkaline compound. So this character that means the amyloglycoside cannot be administered by oral, right? Second, sulfate. This all is complex with some compound sulfate. The third, water solubility. The fourth, good stability. It's very stable. Antibacterial spectrum. Please remember, amyloglycosidal antibiotics is a narrow spectrum agent. A glycosides, the mainly has effect to the gram-negative anaerobic baseline. For example, Encentensia coli, Pseudomonas aeruginosa, Clampensis, and etc. Next, some resistant bacteria. For some resistant bacteria, the aminoglycoside has the perfect effect. For example, MRSA. We abbreviate the MRSA means methicillin resistant Staphylococcus aureus. It's MRSA. It's the penicillin resistant. Another one, MRSE, is also the penicillin resistant epidermidis. These two resistant bacterial aminoglycoside has a perfect effect on. A third, some tubercle bacillus, tuberculosis infections, streptomycin and the clindamycin. The clindamycin, now it's the second line of anti-tuberculous agent in clinic. The clindamycin is aminoglycoside. So the aminoglycoside antibiotics antibacterial spectrum is a narrow antibacterial spectrum. It mainly has effect on the gram-negative and some resistance bacteria and the tubercle bacillus infection disease. What is the mechanism of the aminoglycoside action? It's similar as the tetracycline and the chlorophenicol. The aminoglycoside also inhibits the protein synthesis. It can affect all membrane incompletely. They are bactericidal drugs. It's different from the tetracycline and the chlorophenicol. The tetracycline and the pharmacology is the bacterial side drugs, and the aminoglycoside is bactericidal drugs. It's different. And this line shows the protein synthesis process of the bacteria. And we have learned the tetracycline and the chlorophenicol, it can only binding one target site. Tetracycline binding to the 30th subunit of the ribosome, and the chlorophenicol binding to the 50th subunit of the ribosome. It's the one site. And aminoglycoside, it can inhibit the whole process of bacterial protein synthesis. Aminoglycoside can inhibit the initial stage process of protein synthesis. Aminoglycoside could inhibit the extending stage. The last one, aminoglycoside could inhibit the ending stage of the protein synthesis. That's mean aminoglycoside could inhibit the whole protein synthesis. It can inhibit the bacterial protein synthesis. Please remember. And what is the mechanism of the resistance? What is the mechanism of resistance to the aminoglycoside? The main mechanism of resistance to aminoglycoside is some bacteria can modify enzyme. What is enzymes the bacteria could modify? Acetylase, andylylase, and phosphorinase. And we will discuss in the next slide. And besides the modifying the enzymes, some bacteria could decrease the permeability. As a permeability that can hold or block the aminoglycoside entry into the cell membrane and to hold the high concentration of the aminoglycoside in the cells. By this way, some bacteria also can develop resistant to aminoglycoside. The last one, modification of target site. We have learned that aminocytol could inhibit the whole process and initial stages, expanding stages, and ending stages of the protein synthesis. And during different stages, the aminocytol also has a different target site. If some enzymes could modify these target sites, also can produce resistance to the chlorophenicol. This is the three mechanisms of resistance to the aminoglycosidal. Among these, the modified enzyme is the main mechanism of the resistance. And the target of inactive enzyme, for example, is anti-lysins, acetylene transferase, and phosphortransferase. This enzyme could destroy the aminoglycosidal's chemical structure and to destroy its antibacterial effect. And some bacteria could produce this inactive enzyme to destroy the aminoglycosidal's antibacterial effect, could cause or develop the resistance to the aminoglycosidal. Pharmacokinetics of aminoglycosidal. Please remember, all the aminoglycosidal is less absorbed after oral administration, and we have learned it in the physical characters. It is not stable in the NSAID solution. So intramuscular injection is usually used. Please remember. The second one, aminoglycosidal's distribution is mainly restricted to the extracellular fluid. High concentration of the aminoglycosidals are obtained in the renal cortex and the lymphoid fluid of inner ear. They cannot permeate blood-brain barrier. Chlorophenicol can pass the blood-brain barrier, and here aminoglycosidal cannot pass the blood-brain barrier. Aminoglycosidal distribution, please remember, is mainly restricted to the extracellular fluid. The third, aminoglycosidal are primarily excreted unchanged through the kidney by glomerular filtration. So if some patients, the glomerular filtration is impairment, it's the aminoglycosidal elimination has changed. So it will prolong half-life of the aminoglycosidal in host. This is the pharmacokinetics of the aminoglycosidal. Application in clinical. The aminoglycosidal to the whole body application in inflammation that's the sensitive gram-negative baseline induced. Based on the aminoglycosidal antibacterial spectrum, it has a perfect effect on the gram-negative baseline. So if the gram-negative bacilli induce the whole body infections, in clinical we can select the aminoglycosidal. The second, orally administered to treat the gastrointestinal tract infection, prevention for the bowel surgery and the hepatic failure. We have learned that the aminoglycosidal cannot be used by the oral because of its unstable under the NSAID constitutions. But if we use it by oral administration, it can treat gastrointestinal tract infection. And we can make use of these characters, could treat the gastrointestinal tract infections. The third, external preparation treats the local infection. Local infections. The third, tuberculosis therapy. It's another one, tuberculosis kanamycin, and we have mentioned. And in the later or in the other chapters about the anti-tuberculosis chapters, and you will also learn the kanamycin for the tuberculosis therapy. So this is the application in clinical of the amyloglycosides. Adverse effects of amyloglycosides. It's similar with the tetracycline and the chlorphenicol. The amyloglycoside also has severe adverse effects. The severe adverse effects, we have got these 4 points. And the major severe adverse effects including octotoxicity, and it can distribute it in ear. It's including the nephrotoxicity. Another severe adverse effects is the neuromuscular blockade. These 3 severe adverse effects could cause the death of the patients. And the neuromuscular blockade, the intravenous administration of calcium salt and the neostigmine is the preferred treatment for this toxicity. So before taking the amyloglycoside, these engines should be prepared because of the neuromuscular blockade happened. We can use this engine to rescue patients from these severe adverse reactions. So the 3 major severe adverse reactions, octotoxicity, nephrotoxicity, and the neuromuscular blockade. And the octotoxicity and the nephrotoxicity is caused by the distribution of the amyloglycoside. Besides this, another one, allergic reactions. It's often meant in clinical after taking the amyloglycoside. These allergic reactions also can cause some skin rash, skin fever, and the different others allergic reactions. So this is 4 major adverse effects of the amyloglycoside. And every student, please remember the octotoxicity, nephrotoxicity, and the neuromuscular blockade. These 3 main adverse effects of the amyloglycosides. And in this chapter, we will select one agent to introduce to every student. This agent is streptomycin. Streptomycin is first used in this type of agent in clinical. Streptomycin is the first choice drug to treat the plague and rabbit fever. This is the first choice drug in the amyloglycoside types that is selected to some clinical application. For example, plague, rabbit fever. This is 2 major infections disease. Another one, streptomycin, it could be combined with the penicillins for the endocarditis. It's combined with penicillin as the first choice drug. From this slide, it shows amyloglucosidone can be combined with the penicillin or other beta-lactam antibiotics. It can expand this enzyme's antibacterial spectrum. That's why. Because the penicillin has an effect on the gram-positive bacteria, or amyloglucosidone has effect on the gram-negative bacteria. So if these two enzymes combine together, it can increase the antibacterial for some infection disease. And here, endocarditis is a good example for the clinical application. The last one, streptomycin is a first-line antituberculosis drug in clinical. We have learned the clindamycin. We have mentioned it's a second-line antitubercular drug. And besides this, every student will learn the other 4 first-line antituberculosis drugs. And these antituberculosis drugs all combination together is 1, 2, 3 combination, all are widely used in clinical. Okay, and this is a class of the chapter 45 for the amyloglucosidone.